we've got a few slides that we wanted to go over with you. We certainly will have questions throughout. We want to make this really informal, and I do appreciate you moving up so that we can see you. This workshop is called Getting Started, which I think is rather funny on a Friday afternoon to have a workshop named Getting Started. But, you know, we are the sort of third stool of the Vancouver Stop HIV/AIDS project. You've heard from our leadership team at the beginning of yesterday and throughout the last few days with other members of other people who've been involved in the Stop Partnership project. You've heard a lot from our clinical leaders. In fact, they're hosting a workshop right now upstairs. And we are the project team. So we've been given this wonderful opportunity to give you a little slice of the work and the life we have as a project team supporting a very large, complex project. And so we hope that that's informative to you and for you, and that you have, again, lots of questions for us. So we've worked really closely with our community partners and clinical leaders. They are our champions. We work very closely with the leadership team, and we've had a great time. So I wanted to share some of that success and also some of the things we weren't so successful with. So up on the screen we have all our names and the roles that we played on the team, and I'll speak to you about those roles in a little bit. The next slide talks about, and everybody's got a copy of that in your package, and also I think there's a chocolate bar in case we get a little boring. You can eat the chocolate. We wanted to break the session, keep it very high level, give you some examples of things that we did, but give you kind of a time frame of things that we did in our first 0 to 6 months, maybe a little longer, but what we might suggest might work for you given where you're at now with your Hope to Health planning. So just a brief overview about the project management approach, some of our learnings from 0 to 6 months, a little bit about 7 to 12 months, and some closing thoughts. Can we show that slide on the collective impact? I think you saw this yesterday in the system transformation presentation that Scott and Chris did. And it really shows how the three groups work together and how important it was for us to understand these principles. We didn't have them at the beginning, but they were kind of inherent. A common agenda that came together fairly quickly, but certainly had lots of bumps on the road when we had to talk about decision making on different priorities. We had a shared measurement, and you heard a lot of that from Reka, Jat, and Mark Gilbert, and all sorts of people who provide good data and the rationale and the reason for that good data to make decisions. Mutual reinforcing activities, lots of those, lots of conversations, lots of discussions, lots of documentation. Continuous communication in all sorts of ways and formats, not always the best, but forever having the conversation and the buzz that happens because you're having the conversation, wherever it is, and the backbone support. And that's basically our biggest job, was the backbone. So the reason we are suggesting a project management approach is because this is a complex project. All our initiatives in healthcare are usually complex. Can't do things off the side of your desk. You have an opportunity now with some significant funds to make a difference, and you want to plan and do that well. And our experience is, any of us, if you've been in any kind of activity, when you have a focus group with goals, with clear terms of reference, knowing who's going to make the decisions, how they get made, who you communicate to, who's doing what, how much better and clearer it is. People are always looking for clarity and leadership. So this is the time to step up and provide it. So it gives you credibility in the team, no matter what level you're at, about being involved in something that you can actually describe, know what the goals are and what's expected of you, even if it has to be shared and reshaped and reformatted and rediscussed. It's important. I don't know about you, but time in this world is short, so let's try and do it right. Ask everyone you know that has any information on what you're doing, steal it, give them lots of credit, and take it and run with it. And I'm sure you've all been in those kinds of places, and this is one of them. So 0 to 6 months. This looks kind of scary. Can we just go back? Yeah, well, I think so. I think you're quite right, Gina. I think we should have put that dot up a few rungs.
It's a much steeper roller coaster, though.
I'm sure that's how you feel after 2 days of hearing about HIV and the challenges and what's ahead of you. It's also very exciting. But you also know when you've done any new initiative, paint your house, buy a new house, whatever project, plan a vacation, it feels overwhelming. You start at the bottom and you take those steps up, and that's the only way there is to do it, unfortunately. But we've got some things along the way we think that might help you. So first one is form your leadership team. I think you've heard lots and lots about that. And that was critical to us. Certainly as a project manager coming in, I wouldn't have taken the job without seeing the leadership team. Number one, they wouldn't want to see me without the interview. I don't want to take the job on without the interview. I want to know that these people are passionate, committed, it's all about people and their behaviors and what you see in them. Know as much as you can about the job. That leadership team was critical. Identify your clinical leaders. You've seen a number of ours from Vancouver, and I know you've got lots in your health authorities. They're critical. We'll talk some more about those. Form your project team, and we'll talk some more about that, and we'll go right through this list, and hopefully by the end of today you'll have a bit of a checklist of where to start on Monday morning when you get back. The next slide is just basically on the leadership team, and we've talked lots about that. Our job was to make sure that, and if you don't have one, and you're at maybe the clinical leaders group, or you're somewhere in the project, you want to advocate all the time for that leadership team. Where is it? Who are they? Can we get them together, make a schedule, make some terms of reference, make an agenda, keep them on track? That's the job of the backbone. There's never work left on the table with the project team. Everyone has a job, and you come back to the table with the list of things to do and who was to do them. And that's why it gets done, because it's always in front of people's face. You're trying to make this an issue for everyone when they've got a whole list of 20 other things that are just as important. The champions, can't say enough about those. Those are the people that went out and actually led the change. Yes, we provided them with lots of tools, and we coached them sometimes when they needed help, but these are the people that were either experts in HIV that had to learn a new way of introducing a change. These were people that had clients with HIV and AIDS that weren't their largest group, but they had to now make a change in the way they practice and provided service. And also people that did not have or didn't think they had HIV clients as part of their responsibility had to come into the group. So all sorts of resources and tools, approaches, attitudes, cultural environments that had to be taken into consideration. And these are the people that led that and got the pushback from the front line. So incredibly important to support them. This is our project team, how it looked and how it looks today. It's large. It didn't start that way. We are a large health authority. We have a huge problem with HIV and AIDS. So we're able to hire a big group. But we have been incredibly flexible as best we can to making sure that roles are partnered, all hands are on deck, skills and attitudes and projects get shared around, and try and maximize every resource we have to do the job we have. So project management, evaluation, monitoring, health planning, business, clinical, and data analysis, and admin support. And when I first started doing project management work, I didn't even know what a business analyst was. And I don't know if I really still do. Almost does. But yeah, I know, 2 of them are sitting right there. And but you have a clinical analyst, and those are rare as hen's teeth. Business analysts are pretty special, but clinical analysts are those people that come out of their clinical practice, and they know the clinical workflow, and they can look at it and they can see all the efficiencies and inefficiencies. Business analysts come in and document all that for you and ask you really good questions about electronic documentation, paper documentation, where the workflows are, who else is working in the environment, in the labs, and where they brings that all together for you. You heard in acute care, you can't just put the rec on top of the patient file and say, please just ask them for a routine HIV test. How do you fit that into everyday practice? So that was the role of the business analyst and the clinical analyst we described. We had Danielle as our evaluation lead. We had 41 pilots, and all of them had to have a logic model with evaluation indicators, targets, so that we could measure them, make choices at the leadership table about whether they were going to get ongoing funding or not. Important role. Health planner, that was Lynn. It is Lynn. She did all our front-end work on current state analysis, gaps, those kinds of things that got our plan together for the leadership team to make their choices and decision. And she now does evaluation analyst work too, in terms of helping Danielle. And data analysts and evaluation analysts who are monitoring the slides right now, and our famous admin support that you're seeing at the table today up in the reception area. The project manager's job, I've talked a little bit about this. These are the three key sides of the triangle for a project manager, and it is for anybody who manages. You've got the scope of your job, you've got the schedule that you have to keep to or modify and change all the time, and you've got a certain amount of resources to do the job. And in the middle of it, life. You know, there's a change, there's a risk. Somebody wants to add something on, somebody wants to take something off, some resource has left, the schedule has been shortened, the scope has been broadened, and it's fighting each other all the time, and you're there to help make that work. The challenge I had at the beginning of this job is, and maybe Val could speak to this, was that there was a hesitation in bringing on a project team or a project manager. And so, you know, maybe Val, you could speak to that.
I think when we first found out we were getting the resources for STOP, it actually was at the very end of the fiscal year, and but we were given money for that full fiscal year. It was one of those bizarre situations we sometimes find ourselves in, where we have this massive amount of money and no possible way to spend it, short of, you know, throwing it out the window at anyone walking by. Much as we discussed, I think, very briefly yesterday, fairly quickly, our executive sponsor, who is our Chief Medical Health Officer, took the overall leadership for the project, and then Chris Buckner and myself were given the project sponsor roles, Chris as the Regional Director for Prevention, and myself as the Operations Director in Vancouver Community. And we did a lot of storming, norming, forming in very positive ways. I don't mean that, you know, we were fighting or anything, we certainly weren't, but we had to do a lot of that trying to think through what was the, you know, what was expected of us, what were our accountabilities. The information from the ministry was, there wasn't a lot of depth to it. There was certainly some goals, which was helpful, but we certainly weren't being told how to do it, which was a wonderful thing on the one hand and turned out to be a very wonderful thing. At that moment in time, it didn't necessarily feel wonderful because we were going, ee, you know, and I think as Chris spoke about yesterday, our sort of first dipping our toe in the water was really about trying to do more of what we were already doing, which you know, ultimately was not getting us where we needed to go. It was also trying to do some exploratory work with our community. So, for example, we had a forum with all the community organizations, internal and external, that were working with HIV to start doing a gap analysis. So we were starting to do some of that work, but we weren't ready at that point, or feeling ready to go out and hire a project manager, because we weren't really sure what project they were frankly managing at that point in time. That said, it didn't take too long, and I'll have to say I was fairly vocal about this, that it didn't take long before it was very clear that we needed a seasoned project manager to lead us forward. And so we did that look out there as to who was available, and I can say unreservedly that probably the very best decision we ever made on this project was hiring Sue and getting that resource in. And it probably was a little bit too late. We probably should have done it before we did it. But that was part of our learning, and part of what we would like to share with you is that, you know, assuming you have the resources to do so, that looking at some dedicated project management will take you further, faster, most definitely. So we waited a little too long, and but at the end of the day, we absolutely got the right project manager, and she made up for any time that we lost there by getting on board and assembling her team. So.
Thanks, Val. Because I always think it's interesting hearing the perspective, because the comment we got back all the time was we've never worked with a project team. We have no experience with a project team. We've always done this work by ourselves, or the one we hear quite frequently now is, you know, I have so many great ideas and I feel I never get them to fruition. I don't have the skills, but this has worked. So it's like trying to do 10 things. Maybe you should do 5 things really well and leave the other 5. And know that there are skills on both sides. I've been a senior director. I feel very comfortable with a senior director team. That's what it takes in terms of our relationship. I have to know all of them. I have to know how they think. I have to know how they work together. And I've also got to lead a team. So some of it is control. Some of it is concern that they maybe think they should do it all. Besides control, that I'll take it away or we'll take it away, or that they just should do it all. Versus they're visionaries. They're the leaders. They have the credibility and they have accountability for this project. And there's no debate and question about that. But we are making them able to do this within their already busy day. So if anybody's had that done for you, a nanny or a babysitter or anybody that comes in and helps you, they're not taking over your life, but they're giving you a boost up. So from a simple agenda to planning a retreat, to planning a future state, to whatever is the work of this group and the ones that are upstairs and at home. To make that happen, that's our job, to make them look good and to work just as hard as they are doing this. So it's a really important relationship. I can't understate it enough, overstate it enough.
Can I just ask a question? I don't actually know what most of your backgrounds are, and so I'm just wondering if you can comment on the importance of having somebody who has knowledge of HIV or knowledge of public health or not. I don't actually know the answer.
That's a really good question, because the next one is about hiring the staff, the team. Where did that go, that hiring slide? Oh, there it is. Danielle has a background in evaluation, her PhD's in community psychology. So has done a lot of work with communities evaluating their projects. So if you can imagine that you've got money for STOP, it's not like the money you got for running other things from the Health Authority. We're actually coming in now in a very engaging and positive way, we hope, because that's the way Danielle works, to set your community agency up with targets, indicators, and expectations around this money for 6 months. And from there, if you're successful, another 6 months for the 2.5 years that we ran, you know, the project, which is up at the end of March. That's pretty scary. So we needed somebody who could make that relationship with people and make them feel comfortable that we're all in it together. We expect you're going to succeed. You probably already know what those indicators and targets are. That was Danielle's job, and she brought that experience, and she'll talk about that in a little bit. Lindsay has a master's in informatics.
Yeah.
So that was very helpful. You need techie people on your team, and you also need people who can think about information as a whole. So you're talking away, and you've got these ideas in your head, and Lindsay's already got the picture. She knows, and she goes out. I mean, I don't know how you do that. Lynn has a health planning background, a master's in health planning, and that was terrific to be able to bring all the documents, the recommendations, the reports from different groups, Aboriginal groups and gay men's groups and women, and pull all that information together and from the community and show it to us against the data that we're getting from BC CDC and CFE and the Public Health Surveillance Unit. Kendra has a master's in business and has led a number of our projects, so you'll be probably quite interested in talking to her as well. Acute care testing and testing with family practice. And so works very closely with Reka, who is our medical health officer, who in many ways is our visionary around testing and took that on quite courageous, but she needed a partner. We needed to pair up with somebody so that the two of them could work side by side. So we have linked Kendra up to Reka. You often see them walking together like this, and that's why she says don't go to coffee with anybody on the project team, because she brings her checklist and goes down those things. But that's what it takes to get this project moving forward, to get Reka on schedule, on task, her reports done, her PowerPoint slides done, the letter off to the college, whatever, all needs to be prepped and done. And it's just a ton of work. And so there, it needs to be shared. So be selfish, go out there and get yourself some help, either internally or externally. And we can give you some help around that. We don't have a background in HIV, and in fact, that was one of the pushbacks we had. Well, how can you possibly help us when you don't know about HIV? It doesn't matter. It doesn't matter. An agenda is an agenda. You give us the content. You give us the documents. We watch your workflow in acute care, whether it's HIV or whatever is a workflow in acute care. People come in, they go to emergency, or they go to admitting. You know, it is a workflow that's quite common. So that's where your clinical champions are really important. That's why our skills are there to back them up. That was a good question. Hiring. Obviously in Vancouver, you could think that we are capable of hiring people very easily to be on a project team. It's not the case, because, you know, certainly for the projects that require this kind of complexity, it's hard. It's hard to get good people. And lots of them in the ages of 30 or so have babies, and then they come and they go, or they go for a long period of time, and then they come back. But many of us have worked for other health authorities that aren't local, and we fly up, we do teleconferences, we do all sorts of things. So there's all sorts of ways to use your inside resources and external resources. So that hopefully is a help to you, because you'll need to be able to start with a small team and expand it as your work expands. This, sure.
So this is the project team. So did you also manage Northern Health's rollout of stock?
No.
Or they have their own project team?
As far as I know, I'm sure they must have had their own project team.
Okay. So
Right.
it sounds like that is each health authority project team.
Yeah, yeah. Because you have well, it's not to say that if you were part-time in a role in one project, one health authority, you could do something in another health authority if you were part-time. But if the role required full-time, then you would be attached. And there's a certain uniqueness about a health authority and what their needs and their leadership need and how they work. And as I said, many of us have done work for other health authorities and have traveled from Vancouver, and it's possible, Even in Vancouver, we work a lot on the phone, just because even if they're 2 or 3, blocks down, it's time, right? Oh, is there a question? Oh, the question was, were we also the Northern Health project team? No, we weren't. So the slide I want to show you next is just a great slide that just shows how people can be more than one in one role, which is one of the things we learned. And that's Lindsay, can you believe that? In a Wonder Woman costume. Gina, did you know her then?
Oh, I recognize.
Anyway, just one of the things that shows how a business analyst who can pull a lot of documents and business tools that you need to do any of your implementations. If you have somebody with leadership skills, this is a wonderful way to combine the two. And in my time of my career, this is part of my coaching, new blood. So if you're looking at people with inside health authorities that need some and want some experience, this is a great project to pull them in on. So, over to Lynn.
Okay.
Any questions, sorry? Marlon?
I have a question. Sure. So I might have missed this, but what was the interaction between the project team and the leadership team? I mean, was it the project manager that reported up to the leadership team? It sounds like Kendra worked quite closely with Reka, but how did that reporting sort of work?
The team all reports to me as the project manager, but we all have pieces that we're working on with different project leaders. I mostly work with the project leaders. With the leadership team, sorry, the project leaders, leadership team, same thing. Yeah, yeah. And what's great about the project manager, if you're, you know, good at what you do, or try to be good at what you do, is you get the whole conversation, what everyone's doing, because they're coming to talk to you, and then you know how to coach them or redirect them to say, that's going on over here. Because, you know, 41 pilots, it's a lot of work. And now, we're not only running those 41 pilots, we're also planning our future state. So we're having to develop new service delivery models based on what we learned in the pilots, fund them, figure out how we're going to implement them when the pilot project is done. We're going to have to RFP all the community funding, because we didn't RFP during the project because it was pilot money, so that will all have to be done. And because we knew knowledge exchange was coming, our team reassembled itself, put aside future state, and put together 8 workshops for the last 2 days. So you have to be that able to meet the changing demands. Something's not going well in acute care, all hands on deck. You have to take some risk about that. What will you lose making those choices? But those are decisions you make every day anyway.
Any suggestions for the new teams and all the health authorities linking together a little bit more? Because it sounds like you didn't really have a lot of linkage with the Northern Health pilot. Would you be suggesting that we as, you know, health authorities just coming online get together regularly, maybe monthly or?
Absolutely, absolutely, because we still have lots to learn. Lots to learn. We're, you know, you're only so many, your critical mass is so many people, you can only take in so much. So we have lots to learn. And we know that workshops are being planned, and I understand teleconferences. So, you know, that would be great. And any of the tools that we show you to say, well, how did that work? Well, we didn't do it so well the first time, so we got better.
I see BCCDC doing that a lot for infection control,
Yes.
you know, across the province and making standards for the province and, you know, help guiding them and giving some guidance. And then on the front lines, the health authorities do what they need to do to get those, you know, standards up to speed. But I see this being similar to the rollout.
Because we don't want anyone spinning their wheels when there's somebody on the phone that could just answer the question. Right? So I think that's a good thing to write down on the evaluations. Where's Cheryl? I think she's somewhere. Yeah. Oh,
So I'm Denise from Northern Health, and just one website you may wish to check out would be HIV 101. You can Google it. It's part of Northern Health rollout. So it's got lots of educational information resources, things like that. And you can see part of our media blitz. So if it helps you.
great. Lynn.
Okay. Hi, everybody. I'm Lynn. I'm the health planner for the STOP project team. Move this a little bit closer. So I'm going to be talking about current state analysis. Now, current state analysis is really just a fancy project management term for what's going on in your area or health authority. So yesterday you may have heard Mark Gilbert talk about the data, knowing your epidemic, and earlier today, if you attended the monitoring and evaluation workshop or the building leadership workshop, about the importance of data and how that helps to inform your planning processes, especially in the beginning. So when we started out, we actually didn't have all the available data readily available at our fingertips. And we actually had to set up partnerships and go out there and seek out data at a population level and at a program level across the client journey, from everything from prevention to testing, treatment, and support. And part of our success in being able to gather this information rather quickly in developing things such as an inventory of services was the fact that our clinical leads, have been working in HIV for a number of years, and they know all the service providers and have a sense of what's going on. And so we're really able to help us develop that list together. And one of the other things that we really depended on in the beginning was building those partnerships, especially with the BCCDC and the BCCFE. If you attended the monitoring evaluation workshop today, Mark Gilbert and Kate Heath encouraged all of you to contact them to perhaps get some of that data to understand, what's going on and establishing that baseline. I'd highly encourage you to do that because that was really important for us in knowing where we were when we first started. And so, in the beginning, we had direction from the ministry that we were to increase our testing by 50% and that we were to expand our treatment and support efforts to keep people engaged and retained in treatment. What we also got direction from was, who was really important, was our aid service organizations, our community-based organizations, because they told us through multiple forums, focus groups, what the strengths and weaknesses of our current system were. And from that, we were able to develop, strategies to address those gaps. And some other things that we did in the beginning was, took into account recommendations and advice from several reports that were population specific, that addressed the needs of gay men, women, and Aboriginal peoples. And so basically equipped with all that data and information, what we did was develop a gap analysis, or we did a gap analysis, which is basically just a fancy checklist of, all the advice, recommendations, and data of what we should be doing on one side, and on the other, what we are already currently doing and what we are planning to do. And from that, it basically allowed us to identify what strategies, we needed to start doing now, or that needed to be enhanced. As you all go out and start to develop your own checklists, something you might consider using in addition to your consultations, and the literature, connecting with your community agencies and consulting with your data folks, is the Hope to Health document that the Ministry of Health has provided. So what we got from our gap analysis was basically a list of over 30 strategies, at the time, and proposals that were evidence-based, that had been developed in consultation with our clinical leaders, with our community agencies, with attached costs and deliverables, such as, 1,000 tests. And what we did with that long list, I'm going to pass over to Lindsay to tell you.
Okay, so from the long list of projects that Lynn mentioned, we had the task of deciding what it was that we were going to do with our money. And we had to pull it together in a way that was easy for our decision makers to digest and for them to feel really confident in the decisions that they were making, that they were funding the right things. So as we all know, deciding what is important is a lot harder than just worrying about feeding the cat. So the process that we went through to make the decisions, this was sort of for our first year, I would say, was centered around a one-day retreat where we brought together all of our key leaders and stakeholders that were involved in decision making. And so in preparation for this meeting, we developed, we had some additional meetings with leaders to develop criteria by which we would evaluate these proposals. And we sort of fleshed out some of the detail of the proposals. So not all the proposals had, it wasn't perfect information. So we were bringing what we had to that one-day retreat. Awesome. So in preparation for that, we had our big list of possible projects, and we categorized them according to sort of two axes. So one was according to the key population that the proposal served. So, for example, it was, just thinking with testing, we might have had a proposal that was specifically targeted at gay men. We also had one of our pilots that was targeted just at-risk populations, which was our targeted testing group of nurses that were housed under the STOP outreach team. We also used the category, I guess, general for things where either it was targeting the general public or it was a group of at-risk populations. The other axis that we used was what we refer to as the client journey, and Lynn just briefly mentioned so what piece of, I guess the piece of the experience of where the client is going through their journey of HIV. So for us, we were using 4 key categories, so 1, testing, 2, treatment, 3, retention and care, which we then later sort of re-termed HIV supports, and that so it complements treatment. And then education, which were things that they helped providers deliver better HIV care, whereas the other 3 were basically funding things that were direct patient care. So Sue will talk a little bit more about the client journey later, but those were sort of the ways we categorized our proposals. And so then we ranked them. In our retreat, we had our massive list, and this is just just totally fake data, just an example for you to see what it kind of looks like. And so you'll see the category of the client journey, the population, and then the attached funds of a proposal. And then using the criteria, we came up with a score for each proposal. And then on the fly, we were able to basically rank the massive list of proposals so that our leaders could see collectively which ones do you collectively think we should be funding, and where, at what point would our money run out, and that's sort of represented by where the red line is there. So that tool, if I'll flip to the next one, then was used to develop a graph. So visually, using the information, this sort of represents, do we see any gaps? So again, this is fake data. So in this example, if you see, we have on the bottom axis of target population, and then on the right axis, the strategy. And so in this example, you might say, oh, it looks like we have a gap in the treatment for the population of gay men. So then we would go back to our proposals and also know about what services are we delivering today already, and sort of reevaluate. Are we missing potentially an opportunity here to beef up that particular area of the client journey? And so this was just another tool that we used. The other, again, information that we had wasn't perfect, but so it wasn't always possible for us to break down our proposals specifically to the population it would serve. Sometimes, like I said, they were serving multiple populations. So we did our best to sort of divide up and sort of slice and dice things as best we could. So an example would be with targeted testing. We had, we were targeting a lot of at-risk populations. So is there a way that you can divide them up specifically according to population? Not really. So we had a bucket of general, which you'll see in this sort of second highest purple bar there in the back. So using that, we were able to, as we went forward with our proposals, is sort of re-look at with our monitoring and evaluation data, and as that got better, is do we have any gaps? Do we need to relook at the picture again? That sort of thing. So that's how you can use that tool. You're more than welcome to have that. So, at the end of this very scientific analysis that we did, our decision makers, they asked us to do something very sophisticated, and we called it smushing. And so, at the end of the day of this retreat, we had a lot of really, really valuable work on the table. And what we found was that there were elements of some proposals that we really liked, but yet they were duplicated in some other proposals. So they asked us to basically smush some of the proposals together so that we could do more with our money. Basically getting synergies between one project and another. So in the end, even though our scientific method may have seemed like, well, maybe you didn't need it, but what it did do is it demonstrated to the leadership group that they were all on the same page, and with regards to what they wanted to fund. And again, as I mentioned, you could use this tool ongoing if you chose to. So with that long list of projects ahead of us, we were then tasked with developing a high-level plan to put into action, and Sue's going to talk about that.
So the next slide just talks about the high-level plan. We obviously presented the priorities, the goals, the objectives, the high-level measures of success and indicators and accountabilities, who was responsible. And then we set up structures, task groups, who was going to lead acute care, who was going to lead family practice, who was going to lead the initiatives around targeted testing and the treatment programs. And that was, again, where a lot of the backbone support had to come in to make sure those task groups were formed. The same thing as the leadership team. They had their documents in place and their work plan laid out and reminders who was doing what when you left each meeting to the next meeting. So that was always a schedule of what was coming. What we did prior to this plan, and what we didn't mention, what we did early on, but we also did right before any time we had a retreat to revisit the plan, is we would have a forum with all the service providers, whether they had funding from STOP or didn't have funding for STOP or were potentially going to get funding for STOP. We invited everybody and went through the plan, had small groups to give us feedback. Were we missing anything? I think, in hindsight now, if we were smarter then, we would have asked them to help us develop the criteria for ranking the proposals. So again, when we go through our process for RFPing, we'll look at seeing whether those business processes allows for transparency in terms of they may be posting on that proposal to get funding, but can a collective group still look at the criteria for choosing how funding occurs? So the plan, you have a bit of a depiction of the plan in your folder. It's what we call our client journey. It's on your slide, but there's also a big one in your folder in color. And all the pink slots, squares, show you the funding that came about as a result of STOP. So do you have that's the one, right. So what we tried to show in this picture, and people loved it, which was everything that's currently being funded by the system for HIV and AIDS, and then what we added on in terms of STOP. We didn't add them on, obviously, all at the same time. We did for the plan to show what the plan had approved, but in terms of implementation, we probably should have started with, maybe red or pink, and then go to yellow, and then go to green as they became actually live. We're also asked what initiatives would you start with first now that you have finished your pilots as you go back to your health authorities. And we would say the usual, which is start with those that are more easily implementable than those that are harder, those where you have champions, those where there's proven methods. So for us, for instance, acute care and family practice came last. It was harder. That was a very brand new and disputable activity about whether that was a good thing to do or not. So that took us some time to get those done. But now, going forward in your health authority, testing in all your health authority facilities is a given now. So go forward and we will run a workshop, I'm sure, on testing, and we can show you how you did it and you can adapt it. One of the great things that many of you have in community hospitals, a lot of the doctors that work in the hospitals also work in the community, where it's not the case in Vancouver. They're quite separate, so there's not necessarily a lot of translation from doing that routine testing and that rationale in Vancouver. So this helped a lot of people show, where they were in terms of providing service on the client journey, but to remember that it was a client journey, and it's certainly not linear. I mean, it's very involved in lots of ways to enter the system, but this helped show the plan. And from the plan, we go to hear about Danielle's work, because we needed each one of those pink boxes to be set up.
Yes, and well, the way that we structured the evaluation work is that basically at the start we brought together a committee that involved some of the leadership and also some of the project staff to start to discuss, well, what are some things we're going to measure. And because at that time, the Hope to Health indicators, there were just basically about two, increase the testing by 50% and increase the number of starts on ART. So we thought we've got to come to a common agreement, because we have internal stakeholders and some of our internal teams are going to be getting some additional project money or staff of their own, and we've got some of our community partner organizations that are also going to get funding. So the first thing we did was really to draw up and agree on together with that group of, that small committee and group of leaders, what is going to be our logic model that indicates, well, who are the people who are involved in this? So you've got the populations of interest at the top right hand. And then the inputs are all the different ways in which the money will be spent. And then we add certain boxes of activities that kind of went together, like treatment, care treatment and support. Because one of the issues we discovered almost right away was that it was not just a question of finding people that did not know they were HIV positive, but also there were a lot of people who were lost to care and needed to restart on ART, and there was a case management to be done with that population. So we really wanted to illustrate that aspect. And then at the same time, in order to increase testing, well, we had going to have a lot of marketing strategies and also a lot of linkages and indication with our partners. So those were all the different boxes that we put in terms of activities, and then we linked those to some of the outputs, and basically that was going to lead us to our output indicators. And we had quite a conversation about the outputs, because I think people who know about evaluation know that you're not always sure, well, what's an output here and what's really an outcome. And so we erred on the side of really, I mean, some of our big targets in outputs of increasing testing and linking people to care sometimes could actually be seen, and finding more positive people could also be seen as an outcome, but we put that in actually the outputs. And then in terms of outcomes, because the project was short-term, we really focused in our measurement on those short-term outcomes up to March 2013, because the other ones are usually over 5 years, and that's something that's going to occur in the future. But in terms of measurement, we focused on the short-term outcomes. Another thing that we really had to set up was, where do we get our data? That's always the most difficult question. And so we did have a partnership with our internal public health surveillance unit, also with BCCDC and BCCFE. And after that, we got some of the data agreements with them. And in terms of how do we even share, there's always, a whole review that has to be done. Can this information even be shared, and in what way, and what has to remain anonymous in terms of the data. And we also then had a second cycle of review and negotiation once we add some partners that got money, either community groups, even internally. just because we pick some indicators does not mean that they were already being measured in a way that we could access the data and just plug that in. There was even a report on that, because sometimes there were some data elements that there was no report. It was just at the individual level. And so, especially with our partners, there was a whole making sure, as Sue was saying, you meet with them and, you know, many of them are worried. What now? I'm going to have to report a lot more things. Where do I get my data? Does this make sense? Can I even do that? Do we even have the staff? So we had a lot of conversations with them and training and making sure we brought in the clinical analyst to, you know, do some Excel spreadsheets with them. Whatever they needed, we were there to support them so that they would not have to worry about where the data was coming from and how they would report to us. So we wanted to make sure that they would feel completely comfortable. And there was a negotiation with them. Some indicators, as I'll go in the next slide, were key indicators, but there were some other things that they wanted to measure. Well, then we made sure that we were able to support them in that, and that would be something they would report to us as well. So if we just look at the key indicators, now we've noticed that most of these actually are a reference in the Hope to Health milestones. And I mean, you know, once we had learned ourselves, as Sue was saying, we were not all HIV experts. Once we had learned ourselves, they were not rocket science either, and those were the things that you would want to measure. So in terms of testings, the number of tests, the number of positives that we found, the percent positivity. And we had generally for the percent positivity would be 0.1%, but certain sites would have a certain number of tests that they would agree to target doing in the next 6 months. Doesn't mean they would always succeed, but we gave them targets, some very specific targets, so that they knew. And we discussed those with them, of course. It was not us imposing certain targets. It all depended on what they felt they could be doing at their site, given their size of their population there, etc. Then we had wanted to, this was more of a goal, to look at the stage of the disease at diagnosis and to hopefully find people earlier in the course of the disease, so their CD4 count would be higher. But of course, we also wanted to find people who had a lower CD4 count, because it was imperative to find them. So that was just more kind of a statement of hoping to find people at 500 and above. And then for everybody, we wanted to make sure that how many people were, as many as were diagnosed, they would all be linked to care. And we would follow through until they were linked to care. That was part of the testing. Then in terms of treatment, well, some of the important goals, of course, were to look at the number of clients that would be started, newly started, or restarted on ART, and some of the ones that had been on ART for greater than 6 months and with a suppressed viral load. Because what we found often is that people were suppressed and then they would, you know, slip back a little, and the case managers would come back and really help them. So we had to really look at how long had they been on ART for this particular new start. So that was, I would say, some of the trickiest things we had to measure, and we really had to have more conversations to make sure that we were able to measure that. So I think this kind of gives you an idea of the key things that we wanted to look at. And this was all in the hope of monitoring, again, the client journey in all the different parts.
Thanks, Danielle. Just again to reiterate the importance of people on your team that analyze data and do data support. We've got Jill here. We've got Allison, and Joyce might be somewhere in the room, who actually go out, there she is back there, who actually go out with Danielle or with Lynn to the either internal staff or the providers externally in the community and work with them setting up their data collection systems, Excel spreadsheets, whatever they are. And again, it's really tough. We know how we're not linked electronically and how great that would be if it was all gathered that way and you push a button and in it comes. But we knew that making a difference in the goals that we had, we needed to have data at the program level. It was terrific to have it at the community level when Jat and Reka looked at it from the whole community. But what were the projects and programs and pilots and initiatives that were going on that were connected to that? And if they weren't making a difference, how could we help them make a difference? Or in the end, it might be that the pilot just wasn't working and it wasn't the best fit for what the STOP project was trying to achieve. The next I'll just talk briefly about is communication. We didn't have a communications person on our team, and that was really, if we had the money, that would have been a great asset to the team. But we worked through all the regular communication channels within our organization and outside the organization to get the message out. But we still would have loved to have our own project website that you could turn to and see what was going on that week, that month, that year, in terms of all the great activities that were going on. But we used, the regular newsletters, we had forums, we sent emails, we obviously had different reasons to communicate, and we tried to be, again, as transparent as we could when funding came through or when funding was changing or a meeting was coming and what we were trying to do at that meeting. We did get some feedback at the beginning of our project, and you might get it as well, that we don't know what you're doing. We don't know where the funding's going. We don't know the decisions that are being made. And certainly at the beginning of the STOP project, there was consultation that happened. As you heard from Val, the money came, there was some consultation, and then there was this long period of time where there wasn't much being communicated. So one was the project team was getting together. Two was they were figuring out what they were going to do. And three, there was some, what they called quick wins when I arrived, where there was some obvious need for some infusion of funding where there were people with HIV and AIDS who were waiting for care. And this were somewhere where money could be provided and service could start. Because there was no RFP process, you couldn't share that information with people. You're negotiating with them through a memorandum of understanding, so we couldn't share that. So it was a really tough time at the beginning of the project. So I offer that as an experience that we had. We did use, the next slide also would be great, several websites to get our message out. The Change HIV Story, which was our big social marketing campaign. We used the Center for Excellence's website for quarterly updates on our project. We partnered with UBC Continuing Professional Practice, Professional Development for our Family Practice Initiative. So family physicians can go to that website. Apparently over 3,000 of them go to that website. So in British Columbia, so that's a great one. And CATIE, which is a great partnership we have as well on knowledge exchange. And soon, I think at the end of March, shortly into April, you'll see case studies for all our, well, we chose a number of them that we thought made the greatest changes or were different or something that somebody wasn't doing elsewhere. They'll all be posted there, as well as an overarching document, sort of the beginning of the novel of, what happened in the beginning of STOP until through the end. And some of us had a read of it and was like, oh my goodness, they really did that in the beginning. Oh gosh, 2.5 years ago, a long time ago. Anyway, the next slide shows you some posters that we use. These have been great communication tools, and we're happy to share those with you as well. And I'm going to pass it over to Kendra.
Did you utilize the communications people at all with Vancouver Coastal?
Yes.
In Ontario we have it, so
Yes.
did you go through the...
We did, but I don't know what it was like Interior Health, but ours are really interested only in funded only for risk management. They're on the hot topics, and anytime there's an announcement from the ministry. So when we made the announcement of Change HIV and the ministry was involved, they were greatly involved. They helped us with some promotion in acute care. But really beyond that, they were there. They were always at the table. They came to the table when we chose our social marketing company to do our work, helped us with decisions, flag things that corporately you should be aware of, these kinds of things.
The existing partnerships that are between the health authorities industry sort of tab, what they used to sort of be called, was an existing process that really helped. So, but that's something that can always be supported, and it's really linking what's happening in the health authority to the central communication hub. And so that's something that we can continue to work on from our side as well as.
Great. As Sue mentioned, my name's Kendra McPherson. It's great to be here. I've had a chance to talk to quite a few of you today, and happy to get to know more of you, and looking forward to that. So I was leading 2 of the STOP initiatives, acute care testing and testing in family practice. I'm going to speak to you a little bit about the implementation plan and the point in time when it was time to actually pull together this plan around the initiatives. So I've identified 4 phases, but I want to recognize that engagement, communication, monitoring, and evaluation is occurring throughout all of these 4 phases. So it's not like you just do one phase, stop, and then move to the next phase. Continual, as with other initiatives that you currently do within your health authorities. I also wanted to mention that, for example, within acute care and family practice, there might be a number of initiatives that fall under this implementation plan. So you might have department level initiatives, you might have facility initiatives. Within family practice, we had individual private practice physician offices. So each of those areas would require a separate implementation plan. You may have a very large implementation plan that's high level, that identifies the order in which you're going out to these various sites. And then you may have a more specific implementation plan that speaks to a specific site that goes into more details. A little bit about the family practice initiative. So over the last 9 months, Tony Reese is here, and he is the nurse that's working on that initiative. We have engaged in with 106 family physicians in their private offices, and it's been a very favorable experience. We've had exceptional feedback from the physicians, and the evaluation to date has rated some of the interactions that they've had with this initiative as being exceptional and excellent. Another component to it has been working with UBC CPD, where they have been delivering webinars and workshops, as well as engaging with physicians across the province. So that hasn't just been Vancouver-specific physicians, and they've also had extremely favorable results. Just want to speak a little bit about the acute care initiative. So Scott Harrison's here, as well as Julie, and they were both leading the initiative at the St. Paul's and Mount St. Joe's site, so within Providence. So there was a real partnership between the clinical leaders and also the project team. So my involvement was really from a project perspective and supporting the clinical implementation that was going on at those sites. And then this morning, Afshan spoke to the acute care initiative, and she served as the clinical lead across the entire health authority and did a lot of interaction with the frontline staff.
I just wanted to jump in because we did very similar implementation for our community clinical programs. So similarly, the role that Kendra had as project lead for acute care and family practice, myself as a project lead, and Megan Tumath as the HIV practice lead, we did this same thing for community, so like primary care, mental health, addictions, that sort of thing.
And there was a lot of opportunity to build on the different sites that different people were engaging with. So as Lindsay mentioned, they were going into those sites in the community first and developed a lot of these materials and a lot of the information and really opened the door. So we had an opportunity to reference those experiences, and a lot of the physicians and clinical leaders that were involved were part of the engagement within Vancouver community and with some of the at-risk testing initiatives that were going on. Okay, so that was the last step in sort of the 0 to 6 month phase. And just wanted to ask if anyone had any questions for any of us that have presented so far before we start to talk about beyond the first 6 months. Well, we do actually want to say that this timeline is very arbitrary. We had just identified kind of first steps and then beyond that, but there's nothing magic in terms of saying 0 to 6 and then at 7 months you start this. It was just a way to break up the presentation.
I guess what we want to say, though, is you're going to let a lot of pressure to implement. And we'd say, what? You know, implement what? So it doesn't mean to say that you couldn't start with an acute care hospital that's not huge and has some champions in it. At the same time, gathering your data and looking at your gap and setting your priorities and engaging with the community and figuring out your pocket of money and how you're going to use that. But you got to have the resources to do it as well. Because there's nothing so awful as losing momentum on a project because something didn't go well. It spreads like wildfire. But when you do something really well, it spreads as well, really fast. So it's a tough one. You know, get out there and implement. You know, and we remember we'd hear from the ministry, where are those testing numbers? Well, the testing numbers really came. They certainly started in the community, but the big testing numbers had to be in acute care, and that was huge. The MACs, the docs, the directors in acute care, the whole processes. You know, if Scott and Julie didn't have the kind of relationship in Providence that they have, it would have been really tough. VGH is huge. It has huge departments that have been there and worked the way they have for years, and to go into any of them is tough, just surgery or just medicine. But Scott and Julie were able, with their particular two hospitals, to start that. And we worked on that buzz to help us in VGH, which I'm sure you all have those kind of stories in your own health authority.
Lynn, can I make just another comment from a clinician perspective? I know nothing speaks better to docs than money, for sure, and for most of us it does. And if the provincial government is there for, you know, putting out this proposal to the entire province, and rather than giving a small amount of pocket money to each of the health authorities to start their own projects, that's a necessity. But from the perspective of the clinicians and getting them engaged in regards to testing, for example, instituting with MSP a new fee code for the docs to test their clients. Just $1, just $2. You know, if an average GP has about 1,000 patients, that's an incentive of $1,000 or $2,000 just to get that testing done. And if the government wants to, you know, institute something like that, you know, the hospitalists who work in acute care, for example, that will go back to the hospitals themselves, and you'll get more buy-in, I think, from administrators at the bigger hospitals, plus the community clinicians out there.
We looked into that. Scott or Julie, did you want to speak to any of that?
I was just gonna, no.
The MSP are looking into a code for HIV testing, because it's been demonstrated as a gap by the ministry and by MSP. So that is a code, one of the new codes that will be coming out.
Yeah, and I know for a fact, as a specialist in infectious disease dealing with HIV, it was GPs, the Society of General Practitioners, who developed the HIV care code.
Yeah.
That was set at, you know, around $80 to start. It's around $85 for continuing care. That's right. That's right. Compared to their average follow-up is $25. So it made a good financial incentive for GPs to actually take on HIV patients, because they realized it may take a little bit more time and it take a little more than a 5-minute visit. So it was an incentive that helped spur some GPs in the community to say, actually, I can start taking on some HIV patients. I'm not so scared of it, because there is some incentive that I may spend a little bit more time with them and have to, you know, update my skills. And based on that fee code, the Infectious Disease Society, which I'm the president of, developed an HIV specialist fee code, 20% above what the GPs were making, because we are the ones who ultimately do. But that helps support our members who take on the, you know, primary crux of treatment in HIV, the specialty work, to take on more HIV patients. So it worked well in that sense. So let's get the testing side of it down.
Well, we looked at the literature on testing, and there was no evidence that testing made any difference. And when we had our consultation with the GPs in Vancouver, they were not interested in getting paid at all for testing. No.
For vaccines, for example, it really worked well. I don't understand why.
So one thing maybe I can say, I can try and project. A lot of the workshops that have been done over the last couple of days have been really centered on how the pilot was run, how the pilot unfolded, and the lessons that are learned through the experience in Vancouver, Prince George, and the North. there are additional sort of central government things that we also work on. And so there's things like regulations, trying to pave the way to, a prime example is, I know one that's come out already, is the inability of nurses to test in rural remote communities. That's something that we've known about, but it's an institutional barrier that we're trying to break down. So there's definitely there's a role that the ministry plays in terms of policy changes that we will continue to work on.
And a good example for that would be vaccinations.
Absolutely.
Like for the pharmacist, enabling them in the
And
public.
the great thing about it actually is the division that I work in has immunization and problematic substance use prevention, and so we actually have really good ties with some other policymakers, as well as good ties with the medical services division and the health authorities division. And so there's ongoing work that is out of the reach of health authority level. You know, that it's out of the reach of the operational stuff. And so those are things that we can continue to report on, and we can certainly, take advice on. Absolutely.
Our experience has been one of partnership with the ministry, definitely. You and I worked close together on a few issues where I needed, the ministry to make action, which they have done. So
it just may take a while.
It just.
But and that's one thing that happened with the pilot is things came up that we had absolutely no idea were a problem. You just wouldn't think. And it's going to happen in the non-pilot health authorities and the new partners. Things are going to come up that were not an issue in the original pilot things. And that's what part of it, that's what we're here for as well. That's why, we wanted to be fully engaged in this knowledge exchange.
One more point that I want to make, and sorry to divert the attention, but also to the ministry perspective and feedback that clinicians get from MSP billing, and the annual report that we get back as clinicians show us how we fit into our clinical spectrum. So for example, as an infectious disease specialist, I'll get an annual report that says, I've done so many HIV tests, I'm 1 or 2 standard deviations above my colleagues, and when you get flagged by MSP, it's a bad thing, right, for clinicians, because then you'll be reviewed, and they'll go through your charts and do a chart review, making sure, and I would suggest for HIV testing, as one of the tests that you're reporting, I'm always 2 standard deviations above that because I'm infectious disease, but still, it would be important for GPs maybe to reverse that and say, are you 1 or 2 standard deviations below the number of HIV tests you should be doing? And that might be a negative, incentive to.
Interesting. Yeah. Good to know.
And that's definitely come up with our engagement with family physicians in Vancouver. They speak to that report, and it's something that we have started looking into as well. So. Yeah.
It hasn't come up in the family practice initiative about getting paid for testing from the GPs, but we do remind them about the fee code, about working with a public health nurse if they do get a positive.
Yeah, and that's something that we've incorporated into our presentation. A lot of the GPs that we've engaged with weren't aware of that or didn't think of it in this context, so we bring that information to them. Okay, so next slide, we'll talk a little bit about 7 to 12 months, and again, these are just arbitrary numbers. So here we are at the top of the roller coaster, and we're looking down. Lots of anticipation, maybe a little bit of hesitation for some of us more than others, and basically there's no turning back now. Okay, so we haven't gone into as much detail for this next stage because this workshop was really about getting started, but we wanted to include some key points, and there is also a handout in your booklet that looks like this, which just lays out a resource for testing, and this was derived from testing in the community setting, so it's 2 pages, color-coded. So some key points around implementation is establishing the check-in points, and certainly in the Family Practice Initiative, it's something that we do now. When we first go into a physician office, we establish an opportunity to come back, and we want to be able to come back to check in with them. We also want to come back to present the physicians with their data to show them the change in testing from when we were first there. So the physicians that we've been engaging with have been very excited to sign up for this, and it follows the same format as the reports they get about the PAP tests, the number of PAP tests that they're doing over a period of time. And in between when we first go and when we return, collate the data, and then present back to them in a report format so they have an opportunity to see the increase in the tests. This is all information that they authorize to see, and we don't share it with anyone else. So if someone is not interested in that, we wouldn't collect their data. We need their permission to be able to do that. When we go back to do that check-in, we provide support as needed. We're responsive to their questions, responsive to their needs, and a big piece of it is just really following through with what they raise and being sure to find the answer for them if we don't know it ourselves. And then start to share some of the stories that we've been collecting as we've been engaging with so many physicians, and the stories that they're sharing as they start to test. Also part of the Family Practice Initiative are these workshops that are being offered through UBC CPD, and we do that as a Workshop A and a Workshop B. So Workshop A, they learn about testing, and then they come back 2 months later, reconvene, and talk about their experiences. So we actually just had a Workshop B 2 nights ago. Those physicians came back, and a number of them had 100% offer rate. So they had actually found it quite easy to incorporate routine testing into their daily practice, to include it when they're sending their patients for blood work, and just reported back that the patients were quite responsive to that, and it wasn't as they had expected. So it's just a really great environment for them to have an opportunity to discuss those challenges and look to see what tools would help them to continue to maintain that momentum. Okay. So this is about reviewing and checking in regularly. And just a picture to say, here we are at the busy airport. So you see the check-in, so many people, so many lines, but it's a very necessary step. You might initially be concerned as you approach this office and say, oh, I just want to check in. But really what we found is they're very responsive to hear from us, and they do appreciate us coming back to see how they're doing and also to hear from us. So that's been very favorable. We take the time to do it well, to address the concerns, and also to focus on the goal. So just an opportunity to reiterate the importance of testing and how we can support them to do that. It's very similar in acute care, so we're taking experiences across many settings and just applying these same concepts over and over again. So as I mentioned, more details about all of the phases are included in your handout. I'm not going to go into detail about those. Lots of information. We're happy to provide more information, happy to share. We have lots of tools, lots of reference information. And one of our big achievements around the Family Practice Initiative is that it was CME accredited. So as we go and speak and engage with these physicians, we're able to offer them credits, and that's been something that we found very valuable. So.
Any questions? Okay, we're going to just wrap it up with some closing thoughts, and hopefully you can give us some of your ideas that we can take away as well. What worked for us? There's our list. Passion was palpable. This was a project that people self-identified, many of them, to want to be part of. And we were lucky enough with our partners and our clinical leaders and the community that we worked with and ourselves that people were excited. This was a project to be part of. The partners were sincere, and I truly believe we all in all parts tried to be extremely honest with our communications. Everybody has a role to play, and when you're the health authority, again, it's always a tough balance. Data drove decisions. You've heard lots of that already. Processes were transparent. Approaches were focused, and again, it's back to that project management approach. You know, if you're going to take an approach, you're in there engaging first, trying to find out where people are at and what they want to do, what they think is going to work for them. Keep it focused, keep it personal into their workplace, and follow through. Risk-taking was expected. It's tough in healthcare because, again, I think you've heard, we're not known for taking risks, because when we do, it involves client care, it isn't a great outcome. But we did take some risks in terms of the funding and some of the decisions made, and that was very exciting. Communication was all encompassing, and we've talked about that. And successes and failures determined what came next. And fortunately, for us, we had a lot of small successes that just built on and built on. And I think when we looked over time, we would say, my goodness, like anything, you're so engrossed in what you're doing that you hardly have time to step back and look at that. The challenges was the scope of the challenge, the 3 years, the multitude of pilots, the multitude of stakeholders, the relationships with funders, partnerships. One of the things that we in the project team have learned how to do, and that really comes with experience, is there's the perfect way to do it, and then there's the great way to do it, and then there's the way to do it that is good enough. And I hate doing good enough, but you can't always be great at it, and you can't always be perfect at it, but it's enough to keep the project going, to keep the decision-making going, to keep the transparency going, and it may not be as sophisticated as you'd like it to be in terms of presentation, or it may not have all the nice bells and whistles around it, but it's good enough to make it go forward. And that's really important and hard when people are used to something better, or even something not even as great and they think it's great. So it's always kind of cutting off the edges so that you can keep it moving forward, because you just don't have the time and resources to do it, and we all deal with that. The reality of the environment's competing priorities, and that's another toughie. As a project team, you have to keep this project front and center to everyone that you're working for. And that is hard. It's hard to do, but it's also hard for the other person because they've got other priorities. But you have a timeline, and you have a certain amount of resources that are going to end. So you can't apologize for that. But if you work with them and you support them, you cannot believe how much support you get from people who are really busy and do what you've asked them to do, because they know you appreciate it and you know that you've helped them as much as you can to get that information. So it's like everything, you ask a busy person to do something and they'll make the time to do it for you. And that has been tremendous. The stamina needed to maintain momentum. This is tough work. We've all done things that are tough. This has been tough. And all we can say is just try and find the joy and the fun and the laughter within your groups. And because there are days when going outside the door is just too hard. There's too much going on. Some closing thoughts. These steps that we've shown you apply no matter what the size of your initiative is. We hope they're helpful. Remain calm. Sometimes that's hard. Sometimes you have to have a chocolate-covered cookie to do that. Set up your safe sandbox. In all my working life, I've always had a sandbox, which is where I would go, where I know I could be safe and talk about what I needed to talk about, share what I need to share. And we create that on a project team. Every project team I've either led or been part of has had a sandbox. And that could have, whoever in it. But there are days when you need to go there. It's just tough, and you need to go to your sandbox. Or call a friend, like those shows that tell you if you don't know the answer, call a friend. And the main thing is to keep the main thing. And I have that card in front of me on my desk. And that's about scope creep, about the schedule changing, about some angle on the project that we haven't thought of, and oh my goodness, and then back to keep the main thing, and it's a balance. Be ready for anything, and we've had days like this, and again, I'd say go to the sandbox, or call a friend, or have a cup of tea, or celebrate. The next page is our project team. We celebrate birthdays, we celebrate anniversaries, we celebrate people getting married, having babies, we celebrate just about everything. And we have, yes, we celebrate our successes. And we do that with our clinical leaders. That table every week, sometimes twice a week, has our leadership team, our clinical leaders and community partners, and ourselves around the table making decisions. And it's been a lot of fun, and learned lots, and they're the kind of projects that people want to be on, and the momentum builds itself. Once you have it going, people are keen to hear what you have to say, and you're keen to get from them their advice and direction. So just to remember too, we have friends in very high places who are working as hard as we all are to end HIV/AIDS. So thank you very much for your attention. And do you have any questions for us or anything, comments you'd like to make?
Thank you so much.
You're welcome.
Can I just say one quick thing? Sue, thank you very much, and I've thanked you a number of times and your team over the last number of years. But one thing I'd like to stress is that the health authorities that are sort of new to this program are a leg up on the pilot groups because they did not have goals and targets and milestones. They had basically free reign to sort of try stuff and be innovative. And the last 2 days, like really honor the fact that you've taken in a ton of information over the last couple of days that has really catapulted you into the process to try and shortcut a lot of the twists and turns that Sue and her group talked about. So just really, it seems like an awful lot, but you know, you're already ahead of the game after these last 2 days.
And I know there's going to be lots of opportunity for us to get down into the weeds about how we did the work in terms of the project work along with our clinical leaders. So that will come, and I'm sure the teleconferencing idea will come as well. So you're not alone out there. Okay. Well, thanks everyone. Have a great weekend.